surgical complications, you know, complication is always embarrassing for the surgeons, and as a surgeon we like to manage the complication because it is challenging, but the complication of others, not ours. As Einstein said, the genius people learn from the others' mistake. Yeah. My topic today is one of the bile duct injury is one of the most serious injury of laparoscopic, a complication of laparoscopic cholecystectomy. Though it is rare, but it's really difficult to manage or can affect adversely the life of the patient. Anybody knows who this is? Mr. Sir Roosevelt. And anybody knows who's that gentleman? I guess is. I will start this. Mr. Anthony Eden. He was Prime Minister, of England, but he was lucky, and when he was the youngest or younger Minister of Foreign Affairs of Britain, then he followed Roosevelt and he became as Prime Minister. But unfortunately, he was unlucky when he had laparoscopic cholecystectomy in 1953. And this, his saga or malhama or saga, his medical history was published in Annals of Surgery. Sorry. It was published. So it was published in Annals of Surgery, talking about his problem when he had laparoscopic cholecystectomy in 1953. Unfortunately, he did not do well post-op, and he developed biliary fistula. And strange enough, that he was operated by the surgeon of the royal family of that time, Mr. Evans. They did fistulogram for him, which showed the bile duct filled in the upper half, and distally there is no filling of the contrast. And by chance, Dr. Richard Cattle from Boston was there in London. Then they meet together and they decided to take him to Boston in States, where he had hepaticojejunostomy. And unfortunately, he was operated 3 times after that because of hepaticojejunostomy stenosis with recurrent cholangitis and high fever. And he has very tough time. He was operated 3 times, and finally, by chance, he died from prostate cancer. This was 50 years ago or 60 years ago. Mr. Sir George Grey Turner, he commented about these injuries, and he said that these injuries cannot be regarded as ordinary risk. But fortunately, Mr. Abdurrahim Musa, or Prof. Abdurrahim Musa from California, hepatobiliary surgeon, he claimed, or he mentioned that 20 years ago, he said, this bile duct injury can occur to any patient and with any surgeon and at any hospital. So he believes there's no surgeon immune about common bile duct injury. Our question, is it preventable? Can we prevent such bad complication? And the laparoscopic cholecystectomy is one of the most common surgery over all the world, maybe. In Saudi Arabia, at least in each hospital, you have daily on the OR list at least 3 to 4 laparoscopic cholecystectomy. And unfortunately, most of the patients, they are young, from 20 to 50 years old. So if one of them got this complication, he will be in trouble, and he might need repeated surgery many times, and will have a lot of complication. This is what surgeon come in the next day or 2 days after, and to find his drain with this greenish fluid. Very sad feeling. This post-cholecystectomy. And here, the surgical ego, some surgeon will appear, surgical ego of them. They will say, I did my excellent operation. I will do nothing next time. And if you have a lot of surgery, you will have such complication. I did my best, but the patient died. Other patient might have depressed and will have sad feeling, and because it's really embarrassing for the surgeon and the patient. And the other try to deny the problem, put their head in the sands. I know one consultant, he was worked with him when he was senior to me. He was trying to deny the problem, though the bile leak was very clear, for more than 2 weeks. He said, I don't know, maybe he was waiting for a miracle to occur, but it didn't. This one, this is the ARCB. So when you immediately find or suspect the problem, you start the investigation. This is the ARCB of that patient we showed you the bile leak for him. Here you can see the stenosis at the common hepatic duct, and here is picture from the net. You can see how the surgeon was confused or a lot of clips, so it might be difficult. It was a miss. You can see how many clips there and here and there. Maybe he had bile leak or he had bleeding. This is BTC for him. You can see the dilated intrahepatic radicals and no show of the distal biliary tree. And those patients will end with hepatic originostomy. Of course, need laparotomy and hepatic originostomy, and it will solve the problem. But the patient had laparotomy. You see that what's supposed to be keyhole surgery, that 3 or 4 incisions, small, 1 centimeter, 2.5 centimeter, became very large laparotomy with extension here for good exposure. And this is a keyhole surgery, became like very huge keyhole surgery. And this is not the only problem. The major problem is the long-term effect. In this study showing what is the long term of biliary reconstruction, like hepatocytostomy, what the patient might have. The short term result is like morbidity, mortality 3%, morbidity 20%. A patient with hepatic originostomy will have bile leak, abdominal abscesses, dehiscence, biliary fistula, like the usual operation for major hepatobiliary surgery or abdominal. But the most important is an anastomotic structure and long-term effect. The anastomotic structure, which occur in 11% of cases, which will lead to cholestasis, recurrent cholangitis, liver abscesses, cirrhosis, and in experimental trials, there might be question of that anastomosis might be carcinogenic. This table shows the incidence of bile duct injury in the open cholecystectomy. It is different. It ranges from 0.1. Sorry, it's here. The open by mistake. It's 0. It's up to 1.1. From 0.4 to up to 1.1. But in laparoscopic cholecystectomy, and it is between 0.1 to 0.6, 0.8, and recently, even in two papers published in 2015, the general usually the average is 0.4%. A large Italian survey, which they studied retrospectively 56,590. Also, again, they conclude that the bile duct injury, major bile duct injury rate is 0.4%. And the other famous study or survey is Swedish survey as well, which is in 2006. They have studied 152,000 patients, sorry, and they concluded the same. It is almost looks like 0.4%. Our study, retrospective review of 1340 patients over 10 years. It was done by my university group, where I was there for the last 10 years during my practice. University group at King Saud Medical City, and as you said, 1,340 patients. The acute cholecystitis constitute about 14% of them, and the conversion rate to open was 0.4%. The bile duct leak, we had 8 cases of bile duct leak from cystic duct leak, and 0.6%. And we had 2 cases of bile duct injury only, which account to 0.14%. One case was discovered during surgery, and hepaticogestomy was done, and the other case was discovered after post-op due to biliary fistula, and it was a minor laceration of the common bile duct and managed by ERCP. Our group were 4 consultants, or each one of them has 10 years experience in laparoscopic cholecystectomy, and 4 attending or senior registrar. Most of them, they have 3 to 4 years experience in lab quality. This was at the beginning of the studies. And all cases, this was our unit's policy, that all cases attending or senior registrar must be there, or consultant, even if it was done by resident. So just to review about the causes and prevention very quickly, this is normal biliary tree, right hepatic duct, left hepatic duct, and cystic duct. And this is normal ERCP picture. And here just to know, surgeon, he should know about the anatomical variation of the biliary tree. A lot of them are low insertion or parallel insertion, and the most important here, this is a rare condition, but the most important here, when you have wide and cystic duct, if the stone became here and impacted in the Hartmann pouch, patient is going to have difficult laparoscopic cholecystectomy, and he might have some sort of Merisi syndrome. And there are anatomical variation as well on the blood supply. The most important here, you have to know that in 6% or plus, you might have 2 cystic artery, double cystic artery here. So when you have one anterior and posterior in colored triangle, as well, always most of the cases, there is a posterior branch. If the surgeon would clip here, he will find posterior branch. It's very important to avoid bleeding during surgery. The injuries of bile duct injuries which occur during laparoscopic cholecystectomy is usually more severe and extended to higher levels comparison to open cholecystectomy. This is one of the patients. You can see how the injury at the confluence of the common hepatic duct, right and left hepatic duct. Professor Bismar from France, he had the classification of the bile duct injury. This was at the era of open cholecystectomy. And here, type 1, type 2, type 3, type 4. This is the most common, maybe, type of injury would occur. And more recently, Prof. Strasberg from California in 95, he did another modified classification, almost same like Bismar's classification, but he elaborated more on the accessory duct or sectoral duct or right hepatic duct injury. There are many classifications like Hamburg, and this is the Strasberg classification, and more simplified classification like Stewart Way, class 1 partial injury was significant injury to the common hepatic duct and complete cut and transection of the common bile duct and right hepatic duct injury here. 60% of injuries are under class 3 and 20% class 2 and then 10 for 1 and 4. Experience issue is experience play a role in preventing the bile duct injury, and the early reports showed higher incidence, that was in the 90, after 90, between 90 and 2000, higher bile duct injury in laparoscopic cholecystectomy than open chole, due to learning curve. One study showed that it was in 201, 2/3 of cases occur within the first 100 cases of the surgeon lab call. And strange enough was one third of these cases occur after 200 cases. The surgeon has done 200 cases, still he had injury as well. So, and still beyond, still that the bile duct injury might occur after or beyond learning curve. What are the causes, the possible causes? The possible causes is misidentification. The surgeon will misidentify the cystic duct, the common bile duct, and consider it as cystic duct. And most of the OR reports, you will find the surgeon reported as there was secondary cystic duct or accessory duct. What will happen if the surgeons did during surgery did the traction medial and cephalade? What will happen? There will be tenting of the common hepatic duct, which should be like this here. There is tenting like V shape here, and the surgeon, they will have some illusions or visual illusions, and will believe this is like cystic duct, and will go and clip here. Then after he continue, he should cut the common bile duct up at the level, at higher level. This is exactly what will happen if you do retraction, or the surgeon did retraction cephalade and medial, while actually there must be the retraction, the ideal retraction should be lateral and caudal as well, and should not be very extensive retraction, because if you did more extraction, you will have that tenting and V shape as when we showed before. Here there are two pictures from the, you can see 2 cases of difficult cholecystectomy. The surgeon here, the retraction is not good, but he, luckily enough, he could identify a cystic duct. Otherwise, if he went in this area, he will have common bile duct injury. Here, one of the difficult cases as well, you have very wide and cystic duct and short lying on the common bile duct. Such cases are very difficult and can be managed in subtotal cholecystectomy. The other second misidentification is when there is apparent right hepatic duct. It's usually underreported because asymptomatic. If the surgeon, here there is MERCP, which actually is present in 2% of the patient. This is MERCP showing this is sectoral duct or this duct, which is coming from segment A to bile duct. It is very difficult to identify during laparoscopy, and more vulnerable to injury. Injuries attributable to improper technique. Failure to occlude the cystic duct will have bile leak from the cystic duct. The excessive deep dissection as well, when the surgeon goes down to VA sulcus here, this area, you should be, as always, in surgery, we have to stay close to the gallbladder. The golden rule, have to stay close to the gallbladders. And if you did extensive dissection here, going to digging in the porta hepatis, you are going to do the miss or to do injury. Thermal injury, when you do a lot, if the surgeon have bleeding, and he will do a lot of cautery in color triangle, might lead to thermal injury, which conducted to the common bile duct, which lead to stenosis. When should we be cautious? If you have elderly patient, if we have male patient, and when you have acute cholecystitis, all the reports reported 3 times injury more than in acute cholecystitis, more than elective lab chole. And this is what will happen, because in acute cholecystitis, the common hepatic duct will be retracted more toward the gallbladder neck. And also when you have chronic inflammation with dense scarring like chronic cholecystitis as well, the dissection color triangle will be fibrosed, and the dissection will be very difficult, and the incidence of bile duct injury is higher. This is Meniere's syndrome. We have reported our experience in Meniere's syndrome treatment, and at over 10 years we have 34 cases. Most of them was type 1 Meniere's syndrome, which managed by subtotal cholecystectomy. And if you have intraoperative bleeding, if some surgeon have bleeding during surgery, they will get panic. They will try to put clip here and there just to stop bleeding, and this might be a cause of clipping of bile duct injury or right hepatic duct as well. Apparent anatomy, we mentioned it. So after that, in a review of 2003, 70% of surgeons answered to questionnaire that this injury cannot be avoidable. But I'm not very sure now if we did the survey now more, maybe we might have less than such number. What should we do to prevent the common bile duct injury? We'll proper technique that first of all we'll do anterior dissection of peritoneum to collar triangle from the edge of the cystic duct toward the liver, and next step is a posterior dissection from the edge of the gallbladder to posteriorly toward the liver as well, and always we'll go dissection high, close to the heart-lung pouch, as we said, stay close to the gallbladder. Some surgeons prefer to go and dissect the cystic duct and go closer to the common bile duct. In fear, they don't like to have, which is called post-cholecystectomy stump syndrome. But her incidence is between 1% to 2%. I prefer to go high as much as you can. And after I milk the common bile duct or cystic duct, if there is a small stone, push it up, and then I do clip higher as much as I can. No sharp dissection. I don't use hook at all in colored triangle. Some surgeons use it, but I avoid it, and then achieve the critical view of Strasberg. What is it? This is the posterior dissection here. Some surgeons, they don't do it. They dissect anteriorly, then they immediately go and around the cystic duct without showing what is the structure behind. This is the structure. This is a critical view of safety. I always try to do it and achieve it in my cases. Here you dissect anteriorly and dissect posteriorly till you see the window here, and you can see the liver tissue behind, and only one structure is going there. This is cystic artery and cystic duct, and we go and clip here safely. They are here. You are 100% sure there is no tinting, and CVD is here, sitting here, is not there. And so you have such pictures. Some Indian surgeon, they said this is similar to like elephant trunk. Yeah. Critical view of safety. There are many studies that if you achieve critical view of safety, you will have less of bile duct injury. Here is picture showing infundibular technique, and it's not done. But here, cystic duct very clear done. This is common bile duct, and this is cystic artery. Why I'm showing you the picture? Because next to this, if you see here, after the surgeon finished, there is posterior branch. He had the bleeding, and fortunately, this case is easy. You can touch it. You can hold it here. You can do it by hook, or you just cauterize it. But if there was dense and adhesion, you will have a problem to control the bleeding. So you have to avoid the bleeding. Always expect double cystic artery or posterior branch. Minor bleeding, you can control it by pressing the gallbladder on the liver, and then if there is profuse bleeding, ask for suction, and if it is cannot be controlled, you can convert it to a pin immediately. This is a posterior branch with bleeding, and then we're talking about role of on-table cholangiogram. Does it reduce the common bile duct injury? This is a on-table cholangiogram, laparoscopic cholangiogram. You can see the normal biliary artery here, and there is a good study from Lawrence in 2003 that a retrospective review of 252 cases of bile duct injury. They found that on-table cholangiogram was done in 43 cases, but unfortunately only 9 were interpreted as correctly by surgeons. maybe surgeon was under stress and he was not able to identify what is the mistake there. Like such this cholangiogram during surgery here, it was interpreted as normal because you can see the duct and you can see the duodenum is filled, but there is no show here of the upper or proximal part. Do not hesitate to open. As for our junior surgeon, this conversion to open is not a failure. If you suspect bile duct injury while you are doing laparoscopic cholecystectomy, call for second opinion. It's not a shame. Call your colleague, call your senior, and take his opinion. If bile duct injury is confirmed by cholangiogram, or if you open, even if you have experience in doing hepaticogynostomy, don't do it, and calls hepatobiliary surgeon if it's available. Success rate in the hand of hepatobiliary surgeon is 90%, while in primary surgeon was 35%. If the hepatobiliary surgeon is available. If not, if there is no senior colleague or nobody experienced in doing hepaticogynostomy, you can just close the abdomen with large side drain and refer to higher center. Don't do more dissection. Don't do further damage. As I said, if the way things went wrong, don't go with them. This is very nice here article. All of the general surgeon who had bile duct injury will love it. And Lawrence here virtually reviewed 250 cases and reviewed the 250 videotape of cases which bile duct injury, and he believes that 90%, 97% of cases were due to visual illusions to the surgeons, and only 3% due to improper technique. Like here, the visual illusion, you can see the triangle in black, but all of us, we can see the white triangle. Why? While it's not there. And he explained how that it can occur during surgery. He went in the psychiatric psychiatric analysis of the decision making. But other surgeons don't agree with that result. They said to have error, the human, but we should expect more from a surgeon. So, who is a surgeon who has low risk errors? A surgeon who expects unpleasant surprise during surgery, who accept input from others. There is one article, very interesting, that he said the surgeon, he was asking his assistant during surgery, are you happy about the anatomy? Are you okay? You agree? Then he do claim. And ready to modify hypothesis if other colleagues suggested something. Recognize that if he is feeling fatigue or under stress and low threshold to open, and doesn't hesitate to take his second opinion. As they said, to have complication is bad luck, but to mismanage it is bad medicine. The best management is to avoid the injury. This case showing bile duct injury here, and was bleeding as well from right hepatic artery. Usually the major bile duct injury associated with major vessel injury as well, like right hepatic or common hepatic. And always have a good relationship with your anesthetist, your radiologist, and gastroenterologist in the hospital, because it is teamwork is the secret behind the successful surgery. This is some picture from my home country, Syria. Syria nowadays in trouble. Please, let's pray all for Syria and Syrian people to have peace. Thank you very much.
Thank you, Dr. Thank you, Dr. Bismar. It was good talk about painful complications for both surgeons and patients. I suppose many questions.
This is Dr. Manoj. If it is an inflamed and dense adhesion in the gallbladder, can we go for fundus first method and extracorporeal knotting?
Yeah, you can do that. It is one of
it
the
is highly
alternative
preventable
technique
in this
difficult
condition.
cases. But if you see it before or you try it before, it is really difficult. Especially if it is long gallbladder, you will have a lot of bleeding. You can do it, but the best maybe it is very safe to do subtotal cholecystectomy. You go to the heart and pouch 2-3 centimeter, but you have to make sure there is no stone remaining.
And in case of avoiding clips, we can go for extracorporeal knotting. No, it is very
You can use extracorporeal knot. You can use loop as well. Already made loop. You can use it if you feel happy. It's okay.
And if not available intraoperatively ERCP, when to do next? If bile duct is injured, when we have to go for ERCP next follow?
If not available.
Immediately.
If you don't have cholangiogram, you mean?
Immediately.
And you suspect injury. You suspect injury?
Yeah.
If you suspect injury, you open. Convert to open. Call your other colleagues you trust. Then see if there is, you can do cholangiogram. Even if it's not available, I don't know how to confirm the diagnosis. You have to confirm that unless if you find the common bile duct very clearly cut, you can see it and you can relate it. If you don't have cholangiogram.
So
Cholangiogram should be available in each hospital, but if you don't have...
T-tube.
T-tube placement? What you suggest?
Sorry?
Can you use a T-tube?
Yeah, T-tube. If you can see it, if you can manage the case, you can do hepatic neostomy. If not, you can do, as you said, if partial injury, you can do put T-tube. If not, you can just put large drain and send the patient to other hospital where investigation is available.
Yes, very nice presentation. I would like to add one thing. The commonest injury following the laparoscopic cholecystectomy, the biliary stricture, the fundal traction. The assistant give more fundal traction, We should not ask the assistant to give more fundal traction. This is an intimal tear, which will not be visualized at all. Whereas the serosal tear, we can see there is a tear, we can like it. Intima tear, which will not be recognized at all. We will do the surgery, discharge the patient will come back with the obstructive jaundice later, following the biliary stricture. Very common injury you come across. So you can see the old Balian law about 1975 and all. The commonest cause for biliary stricture is cholangitis. Now you take the book, Balian law, change. Commonest is following the laparoscopic cholecystectomy. Trend is having changed. We have to be careful of the biliary stricture following the. Just would like to add. That's.
Question.
Thank you. Any other comments on the most common done operation, the bile duct surgery?
Thank you so much, Dr. for that talk.
Thank you, Dr. Bismar.